Hi, this is Megan Scott. I spent my year with the City of Alexandria Child Welfare Unit. I'm working with the Family Engagement Group. We bring together families at critical decision points in the Child Protective Service foster care process. The client that I'm working with is a woman named Miss Babo. She is a 26-year-old Ethiopian woman. She emigrated to this country when she was about 6 years old. Her parents speak Amharic, and she speaks a bit of Amharic, but understands it, maybe doesn't speak it as fluently. She became involved with Child Protective Services about a month prior to my meeting with her, although I have been trying to get in touch with her for quite some time. She came to our attention when she went into shelter. At the time that she went to shelter, she was 8 months pregnant and was receiving methadone treatment. Prior to that, she had been using heroin quite regularly, and so when she came into shelter, one of the case managers contacted CPS out of concern for the child. After she gave birth, the hospital notified CPS that the child had methadone in his bloodstream, and there was concern for the child. The infant then went through a series of, health scares over the next month, which they eventually realized was due to the fact that she was breastfeeding. She was breastfeeding and pumping really diligently, bringing her breast milk into the child was in the NICU, bringing the breast milk into the NICU. But what they realized was that there was methadone in the breast milk, and that was preventing the child from getting well again. Okay, so I met with her. The purpose of my meeting with her was to prepare her for a family partnership meeting, which was bringing her and the birth father, any of her extended family, any of his extended family, and the social service providers together to make a plan for the safety and stability of the child, because the infant was about to be released from the NICU. So this is not a therapeutic intervention, and that's one of the questions I want to address at the end of this. Let me tell you about Miss Babo. She is, as I said, a 26-year-old Ethiopian woman, so she's a person of color, black skin. She is very, very nicely put together. You certainly wouldn't think, oh, she's coming from a place where maybe she doesn't have a lot of clothes with her, or she doesn't have what she needs, coming as she was from the shelter. Her hair looked nice. She had on appropriate clothes for coming over. I met her at the hospital for coming to the NICU. She had on jeans and a sweater, and was put together. She was very late meeting me, but she did call about 15 minutes ahead of time and warn me that she was running late. So she seemed very oriented that way and aware, and good at communicating. Her speech she mumbled quite a bit, and like I said, I've been in touch with her on the phone a few times prior, and so she has a very quiet presentation. She tends to mumble. Her emotions, her mood, and her affect matched for the most part. She expressed that she was tired, and so there were times where it was difficult to tell if sort of a flat affect was occurring because of her exhaustion, or if it was occurring for another reason. And so that's something that I would want to explore further with her. Her sensory perceptions were good. Her thoughts were clear. She definitely uses some defense mechanisms. One of the things that we addressed in our conversation was whether she would invite her mother to participate in the family partnership meeting, her mother and any of her extended family. And she talked at quite a length about her mother and her father, her uncle, and her family that are part of this larger Ethiopian community in Northern Virginia. And she talked quite a bit about her perception that within this culture, anything that is negative is not to be shared. It's not to be a public thing. The negativity around drug use. Sorry, my dog is barking and my daughter's letting him in, and I apologize for that interruption. So I was thinking quite a bit about her projection. Is this really what the culture is like? Is this what her mother has expected of her growing up? And at this time, with a new infant, with a grandchild, is this what the mother would anticipate? Would she be capable of change in this moment? So we talked a bit about that sort of through some motivational interviewing and just my trying to address where Miss Babo was with the idea of change within her family and whether she could gain support from her family. We talked a little bit about past trauma with her family. She didn't want to speak much about that. She said there is no trauma, and then she also alluded to harsh discipline and criticism in her home. Again, that's something I would address further if I were working with her in a clinical setting. She was oriented ×3. She's very high intelligence, graduated high school, is working on her nursing degree. Memory functioning was good, other than that she was a little sleepy. Her judgment is good, and she had good capacity for insight. She also was very good at speaking up for herself, and in a pleasant, diplomatic way. When she went in to see her son, she found him on his stomach, and she has read that you should not leave an infant on their stomach. And so she turned him over. The nurse then came when the child woke up and said, "He sleeps better on his stomach," and she just very calmly said, "Oh, okay, thank you. I'd prefer if he's on his back," without raising, any sort of ire. So I thought that she handled that really, really carefully. Her attitude towards me was, like I said, she didn't contact me right away. She was quite suspicious when I would call, and kept putting off any contact with her family. Again, very suspicious. But eventually she kind of came around and began to understand that this process is one that allows for some level of vulnerability among everyone in order to create a dialogue that would lead to the best interests of the child. So when I think about her DSM-5 diagnosis, I would say that she certainly has a substance use disorder. She talked about that and having tried to go through treatment before, and it didn't work, and there was a relapse, and coming back into treatment because of the infant. I also would want to consider a diagnosis around depression. But that would, again, require further interaction with her. Like I said, in this case, the intervention is a mandatory intervention that is, it feels mandatory, so it's not mandatory, technically. So she's been asked to join this family partnership meeting it's been requested by the CPS social worker that is on her case. Now, she can say, "No, I'm not interested in this meeting," and the decisions can then be made through the social worker talking to individual members of the family without everyone coming together, just kind of connect on where they are in the process and what all the options on the table might be. In this case, for instance, the mother really wanted to have her infant, who was about to be released from the hospital, this is the reason the meeting's being held, the infant's going to be released from the hospital, and they're wondering what placement options there might be. The mother would like for the infant to be released and to come into shelter with her. The father would like for the infant to be released, and he also is in a transitional housing situation because of his own substance use. He was going to bring with him to the family partnership meeting 2 sisters, both of which were willing to take the child. She was not interested in bringing her family, and so the question was, if you bring your family, might they be a placement option? And if they're a placement option, for the child is at a place that you can stay as well, so that you can continue mothering your child in the way that you want to. So it's a voluntary meeting. However, because it hinges around whether or not there's a family placement option, or whether the city is hoping to, is needing or feeling like they need to petition for removal, to petition for them to have the legal guardianship of the child, moves it towards a mandatory understanding of the purpose of the meeting. So as a neutral facilitator, I am to present this meeting as voluntary. And so that's one of my questions for you. How do you interact with a client when your interaction is by nature mandatory? When you know it's in their best interest to work with you in this way, and yet to continue to give them autonomy, to continue to give them their own independence and ability to make their own decisions around that. My other question was, especially again working with child welfare, was that prior to meeting with her, as a way of understanding the full case and all of the different people involved, I had read through the OASIS database files, at least 30 pages of contact notes from her CPS social worker, as well as I had made some connections with her case manager at substance abuse, the father of the child. So I had some background and history on her, and alternative perspectives other than her own. So in a case like this, where you have a large team and you're working with them, how do you balance that ability to really listen to the client and to hear what they're saying, while also knowing another perspective on what they're saying? And at what point do you not confront, but provide that the fact that there's a disconnect between these two groups? And as a facilitator, especially once we're seated together, that's definitely an opportunity to reframe and to point out distinctions between opinions. So it was, again, an interesting overlap and difference between being a clinical therapist in that case and being the facilitator. That was especially true around the issue of breastfeeding. Now, when she had the baby and the baby had been sick because she was continuing to use methadone, she stopped breastfeeding. They required that she stop breastfeeding, but she had continued to pump and was planning to breastfeed the child once he was released from the hospital. So knowing that, and knowing that I'm a mandated reporter, knowing that the social worker and the father are concerned about this, I wondered how to address that with her in my role as facilitator, and kind of stay in my lane, but also be aware of the concerns around that for her. The final concern or question I had was, when you bring people together, she talked quite a bit about the trigger of being around the father, because he's the person that she's often used drugs with, and so figuring out a way to be with him and to be prepared in case she experienced tension around that. And really for her, just figuring that out long term was something that she was going to need to do in therapy, but it was something I was concerned about as her facilitator. So if you have any thoughts about those questions, any thoughts about this case, I would love to hear it. And thanks so much. Bye.